Hello everyone. Today we will discuss about an important topic, that is diabetic dyslipidemia. So we will deal this topic in these 6 headings mainly. First is about change of approach nowadays and the triad of diabetic dyslipidemia. Then we will look for the risk factors associated. Then what are the target LDL levels when we are treating diabetic dyslipidemia. Then what about the usage of statins. Then when to consider fibrates. So this is the most practical things which we have to know when we are dealing with diabetic dyslipidemia. So we'll begin now. First is, as we know, the change of approach is mainly, previously we used to consider glucocentric. So glucocentric approach is being changed to more focused dyslipidemia focused approach. So along with the normal glucose targets in diabetes, we have to consider evaluation and treatment of dyslipidemia. So this is the change. Coming to the triad of diabetic dyslipidemia, it consists of 3 things, that is increased triglycerides, decreased levels of HDL, and there will be increased LDL. They are mainly small and dense. So in short we call it as SDLDL. So this is the triad of diabetic dyslipidemia, and whenever we are seeing the report of lipid profile, if we get this picture, this is considered as the most atherogenic profile. So we have to be very careful in such conditions. So this is about the triad. Then third point is about the associated risk factors. So whenever we are dealing with diabetes and if we get dyslipidemia, before starting the therapy, we have to consider some associated risk factors, mainly to look for high BP, that is BP more than 130/80, then obesity or overweight. This is again a risk factor. Then smoking history or family history of ASCVD. So any cardiovascular events in family members. So we have to consider these risk factors. So always take the history and assess for the presence of any of these. What is the importance of that? We'll deal in the next session. So this is about associated risk factors. Coming to the fourth one, that is what should be the target when we are considering treatment of dyslipidemia. See, if the individual is diabetic without plus no risk factors, then the target of LDL should be less than 100. Suppose diabetic plus any one of these risk factors, one risk factors. So in such situation we have to target LDL to less than 70. And third one is diabetic plus already established ASCVD. So established ASCVD in the same patient, not in the family members. So here we have to target LDL to less than 55. So here we have to consider aggressive LDL targets. This is about the fourth point. Coming to the therapy proper. In statins, mainly we will consider moderate intensity statins and high intensity statins. Two things are there here. First, to give examples, in moderate intensity, mainly if atorva is there as a drug, consider 10 to 20 mg as moderate intensity. Then if we are using rosuvastatin, 5 to 10 mg is considered as moderate intensity. Coming to the high intensity, same atorva of 40 to 80 mg is high intensity statin, and rosuvastatin of 20 to 40 mg is considered as high intensity. So when we should use moderate intensity and when to consider high intensity? As we discussed here, diabetic individual diabetic plus established ASCVD. So established ASCVD. For example, the individual might have past history of MI or stroke. So we have to consider high intensity in such individuals. Or diabetes plus any one of these risk factors, one or more risk factors, but the age of patient is from 40 to 75 years. So if a diabetic patient of 40 to 75 years, which we commonly encounter in OPDs and admitted cases, plus if any one of these risk factors are associated, always consider high intensity statin, that is atorva 40 to 80 mg or rosuvastatin 20 to 40 mg. So this is about high intensity statins usage. Coming to the moderate intensity. Now the left thing is, see here also diabetic plus one risk factor, but the individual is less than 40 years or more than 75 years. So in this situation, we have to consider moderate intensity statins. So this is the first thing. Then diabetic plus no risk factor, no associated risk factor at all, no associated risk factor, but the age of patient is 40 to 75 years. So in this case, we have to consider moderate intensity statins, as this age itself is a risk factor. So suppose the individual is diabetic plus no risk factors, but the age is less than 40 or more than 75, then no statin therapy, no statins are required. So this is the thing we have to consider when we are dealing with case of diabetic dyslipidemia. In majority of the cases, what happens is patient will be a known case of cardiovascular disease, for example, old MI and associated diabetes. So he will fall in the category of diabetes plus established ASCVD. And what we have seen is like majority of the practitioners will give the combination of aspirin plus atorvastatin, which will have about 75 mg of aspirin and only 10 mg of atorvastatin. So according to the guidelines, we are not reaching the threshold only, because we are using 10 mg of atorvastatin, which will fall in the category of moderate intensity, but that individual actually requires high intensity statin. So this one we have to remember. Sometimes in combination we will even get 20 mg of atorvastatin. Even that is not covering in high intensity statins. So this is one of the most practically neglected thing in our day-to-day practice. So keep it in mind. This is about statins. And one more important thing about statins is, see, even the dose, whatever I told just now, 10 mg, 20 mg. So such small doses also, even if they don't take on daily basis, it has very high protective cardiovascular value. That's why statins are very, very important. Even if we use it in low dose, not regularly also, but according to the guidelines, we have to follow we have to categorize the patient, and then we have to use moderate or high intensity statins. This is one thing. And one more important thing which I missed to tell is, here we discussed about the triad, right? Increased triglycerides, decreased HDL, and increased LDL. So among these three, if we consider, high LDL is the strong independent risk factor for cardiovascular events. And even triglycerides, increased triglycerides has some adverse effect on cardiovascular health. But high HDL levels, suppose HDL levels are high, it is not independently cardioprotective. So this point has to be kept in mind. That is about the triad. Coming to fibrates. So when to consider fibrates? So once we get the fasting lipid profile, and if we see, so this is done. Coming to fibrates, if triglycerides levels are more than 204, they will say, and if the HDL level is less than 34, so if this is the situation, we can add fibrates to the statins, because many a times we'll get to see triglycerides of about 170, and the practitioners will be in a hurry to add fibrates to the statins, or sometimes even they will consider only fibrates therapy. That is too wrong, because fibrates themselves will not help much in case of diabetic dyslipidemia. This point has to be kept in mind. And one more thing is, whenever we are adding fibrates to statins, there is chances of elevation of liver enzymes, and if the patient is not much tolerable to statins, in point to the myopathy or muscle pain, myalgia, etc. with the statin, fibrates will aggravate that side effect further. So always in such cases try to use the maximum tolerated dose, that's it. So addition of fibrates in such cases may lead to non-compliance of the medications in patient. So this is the important thing about fibrate. Along with statins, important thing is nutrition and weight loss, that is exercise. So this has to be advised in case of diabetic dyslipidemia. Do read more about this very important, very practical topic which we see daily in OPDs. Thank you so much.